So like I said, like start my presentations with a scenic picture or animal or something like that. So this is Glacier National Park. This lecture is inflammatory bowel disease, IBD, and diverticular disease. There are the websites for me and Dr. Hughes' questions for USMLE. There are my Twitter things. I have a lot of cases upload to Montana PDoc. Some are resident level, but a lot are for medical students. And I'll be adding more and doing more with that here pretty soon, I hope. And like I said, I really enjoy general and organ pathology. I really like natural disease. That's what interests me about autopsy the most. And I really enjoy teaching medical students. And I hope as a forensic pathologist, I have a good exposure to all that stuff, kind of more on a superficial, hopefully more like medical student level, so I don't kind of get too specialized and stuff for you. These are my disclaimers. Please pause, read them, make sure they do not apply to you. If they do apply to you, stop viewing the video. One more disclaimer, please pause, read it, make sure it does not apply to you. And then at the bottom is my introduction presentation, kind of goes through my teaching methods and stuff like that, if you're interested. Here are my references. All of them are very good books. There are 2 questions at the beginning. Once again, pause, go through it, see if you can answer it. The idea being that you haven't had this material yet, and then it is a way that helps you retain information as you go through. Second question, once again, pause, go through it, see if you can answer it, and then we'll answer it at the end. So inflammatory bowel disease basically is, as it describes, it's inflammation of the bowel. Crohn's and ulcerative colitis are the 2 conditions most commonly associated with it. And the mechanism is it's basically some type of inappropriate immune response to the gut flora. It has 2 peaks, ulcerative colitis, early and late adulthood. It's more common female rather than male. Like I said, the 2 forms are ulcerative colitis and Crohn's disease, which we'll go into the details are. There is some overlap. I remember as a surgical and residency and stuff like that, you learned that there is some forms of inflammatory bowel disease that don't fit neatly into ulcerative colitis and Crohn's disease. But one thing you learn as a medical student, you're learning the basics. You need to learn the basic mechanisms, the basics of each disease process. The specifics come later with time and experience and everything like that. But I think there's nothing wrong with learning things as a black and white right now, differences, and then understanding that it's not all black and white later when you get out there. And those would be a good example of it. There's overlap between the 2, and sometimes it doesn't neatly fit in either category. So features of it, you have diarrhea, which is oftentimes bloody, especially in ulcerative colitis. It can be up to 10 to 20 times per day. Other features you can see associated with it, you can have abdominal pain, you can have tenesmus, which is a rapid bowel movement. So basically you have literally seconds before you'll go once you feel the urge to go. Nausea can be associated with it. And then there's some extraintestinal manifestations and other things that you can see. It's genetically, it's associated with the NOD2, and there are many other genetic polymorphisms. So ulcerative colitis versus Crohn's disease location. Ulcerative colitis, it's in the colon. That's the place it's affected. Sometimes it can have a kind of a backwash into the ileum, I understand, and also you can see some degree of gastritis associated with ulcerative colitis, but it's a disease of the colon. Whereas Crohn's disease commonly affects the small intestine, can affect the colon, but can affect anywhere in the GI tract. Literally, you could have an oral lesion with Crohn's disease. Distribution, ulcerative colitis is diffuse, and you can imagine what happens is basically starts at the distal part of the colon and basically just erodes the tissue, all of it moving more proximally. Whereas Crohn's disease is patchy. Obviously, if it can involve the entire GI tract, you're going to have patchy. So it's associated with skip lesions, where you see a lesion and then completely normal in between, and then another lesion like that. Ulcerative colitis basically is a mucosal process, so it doesn't usually cause strictures, whereas Crohn's disease is transmural and causes strictures. Wall thickness, ulcerative colitis, it'll thin it out. Crohn's disease, it'll thicken it, probably because of all the inflammation, potentially the scarring, stuff like that. So one thing that really helped me was if you understand that ulcerative colitis, number 1, is in the distal colon and basically just erodes the tissue, all of it as it goes more proximal. And Crohn's disease is Crohn's disease transmural, you can put them all together. So strictures wouldn't be caused by a mucosal lesion usually, but if it's transmural with fibrosis, it would. Since it's patchy throughout the GI tract, it makes sense to have skip lesions. So instead of memorizing them all, try and understand the difference between the 2, and that really helped me. And I hope it helps you. So ulcerative colitis, location inflammation, is like it says mucosa. Crohn's disease is transmural. And if you remember that, it helps you understand some of the complications. Granulomas are associated with Crohn's disease, but not ulcerative colitis. lymphoid infiltrate. Both of them have it, most prominent in Crohn's disease. Presence of fibrosis. It's only mucosal for the most part with ulcerative colitis, maybe a little bit in the submucosa, so you don't see the fibrosis. But since Crohn's is transmural with the inflammation, you get fibrosis, and that's what leads to the strictures. Serositis, you see it in Crohn's because it's transmural, so it goes to the serosal surface, whereas ulcerative colitis doesn't. Presence of a fistula, Crohn's disease is transmural, so if two things get stuck up against each other, the inflammation, you can develop an abnormal tract between the two, and you get a fistula. You don't see that with ulcerative colitis. And then pseudopolyps are prominent in ulcerative colitis, less prominent in Crohn's if they're there. So basically what a pseudopolyp is as the ulcerative colitis is eroding the mucosa, basically all of it, it's leaving a few little spots here and there of normal mucosa, which are the pseudopolyps. All they are is normal mucosa that's present compared to the rest of the mucosa that's absent. Toxic megacolon, though, is seen in ulcerative colitis, not in Crohn's disease usually. The risk for cancer is increased in ulcerative colitis. It's most known for, I think, it's about 2%. But you can see it in Crohn's disease if it involves the colon. So it's basically that involvement of the colon that's most important in the risk for cancer, for colon cancer. Ulcerative colitis won't recur after surgery, but Crohn's disease can. Probably because with Crohn's disease, it can affect the entire GI tract. Whereas if ulcerative colitis affects the colon, if you remove the colon, they're not going to get a recurrence. You don't have fat and vitamin malabsorption with ulcerative colitis, but you can with Crohn's disease because it affects the small intestine. And then extraintestinal manifestations, they are somewhat similar. I already mentioned primary sclerosing cholangitis, and that's seen in ulcerative colitis. Just cholangitis in general, it can affect the eye, uveitis, red discoloration, usually of the legs, the erythema nodosum. They get arthritis, sacroiliitis, and similar ones in Crohn's disease, adding in amyloidosis, and it's not associated with the primary sclerosing cholangitis. So the top left is Crohn's disease, and the bottom right is Crohn's disease. So the black arrows show the lesion, and then in between you see pretty much normal mucosa. So this is skip lesions. It's skipping, and that's what Crohn's disease does. The top left, sorry, that's an autopsy specimen, but you can just see the mucosa does not look right, but that was Crohn's disease. So you see transmural inflammation, the top left and the top right show that, especially the top left. All throughout it, you can see those dark patches. That's all inflammatory cells. So they're from the mucosa into the muscularis. To the right, same thing, mucosa, submucosa, some in the muscularis. And then at the bottom, you can see granulomas, and granulomas are associated with ulcerative colitis. Okay, so this is also Glacier National Park. Sorry, I don't know the name of the mountain there. So this is ulcerative colitis. So you can see at the top left, this is a colectomy. Most of the colonic mucosa looks normal except for the distal. You see all that red, but it's all of it. It's diffuse. So basically the way I look at ulcerative colitis is it starts distally and just erodes that mucosa step by step by step by step, occasionally leaving some where you see pseudopolyps. To the right of it, you can see the black arrow is abnormal. It's flattened. And that is basically the part that was affected. Remember, ulcerative colitis can cause thinning, whereas Crohn's disease is more likely to cause thickening of the wall. So that was ulcerative colitis. It's an autopsy specimen, and so we don't get the best GI tract. It tends to break down everything, but that was ulcerative colitis. So this one is an old specimen. It's become dark discolored, but I still think it showed really good. So if you look at the top left, the whole colon is affected. And if you look at for comparison, the ileum, the yellow arrow, that's normal. So it shows you just the pancolitis effect of it. And then the bottom right, you can see those little bumps. Those are pseudopolyps. Those are basically mucosa that's left when it's eroding diffusely from distal to proximal. So the next one's better. Top left shows one about half the colon. You can see the blue line up there. That shows basically the proximal colon. The black arrow is okay. The distal colon is all eroded, but there's little things sticking out. Those are pseudopolyps. Those are areas where the mucosa was left behind. And then my next one's going to show that too. So the yellow arrow shows a pseudopolyp, and then you can see to each side of it, there's basically no mucosa left. And remember, ulcerative colitis is a mucosal process, a little bit into the submucosa, and so that's what's happening here. And the bottom left, just to remind you again, there's primary sclerosing cholangitis. You kind of get the concentric onion skinning around the bile ducts. That's very commonly associated with ulcerative colitis. There are other forms of colitis, microscopic colitis, collagenous and lymphocytic. These are basically cause a chronic, watery, non-bloody diarrhea. They're an ongoing process. They get biopsied for it and see collagenous colitis, collagen. You see a band of collagen. And lymphocytic colitis, you see a lymphocytic infiltrate. Anytime you see a lot of lymphocytes, you got to think autoimmune disease. So it's associated with thyroiditis, autoimmune gastritis, and celiac disease. Diverticular disease. So these are false diverticula. Sorry, I use diverticuli. I think it's supposed to be diverticula, diverticulum for a single. I'm sorry about that. But so basically they're false. The mucosa and submucosa prolapses through the between the muscle. And so it doesn't carry muscle with it. So it's not true like a Meckel's diverticulum. So there's weakness between the longitudinal bands, and those are basically between the Taenia coli, and allows the mucosa and submucosa to prolapse outward under pressure. Diverticulitis is inflammation involving diverticulum. So mostly diverticula are asymptomatic. They have them. They don't even know that they have them or anything like that. But if they get infected, then it can be more serious, much more serious. So they get inflammation of it. That can lead to, if you get rupture of it, peritonitis, which can lead to sepsis. It could just form an abscess adjacent to the colon, which could have complications. And if it connects up to something, you can get a fistula development. So this is the colonic diverticula. Top left is the outer surface, the serosal surface. You can see the black arrow show some, but there's quite a few through there. And then the bottom right is the inner surface, and you can see the pouches where they pouch out. So you can see how those could actually quite frequently and usually do contain fecal material, and could be a setup for potentially inflammation and diverticulitis. So this is the lumen of, so this is a diverticula. You can see at the top, the lumen of the colon is in the yellow arrows showing where that is, and the blue arrows at the top show the diverticula. You can see little pouches. So I just have to share something. I showed one on Twitter. It was basically a picture just like that, except for it was a fixed specimen. And I remember there was somebody who responded to it with a green puking face, and it was somebody who's in their profile said they were really prominently into medical student education. And I just shook my head. I'm like, why would you have a puking face for a good cross-section of a good pathologic disease process? I don't understand. So to the right of it, you see the yellow arrow. That's the lumen of the colon, and then the blue is showing the lumen of the diverticulum. So you can see where the mucosa goes out there, but the muscle doesn't quite. There's a little bit mucosa, submucosa, but there's nothing left. So it's a false diverticulum, has those two layers, but not the muscle, because it basically pushes out between the muscle layer. So this is a person with colonic diverticulitis. So diverticulitis can present like colon cancer because you have this inflammation at the distal colon, which can cause basically it to obstruct. And so it mimics adenocarcinoma by the fact it can be an obstructive lesion occurring relatively acutely, but when they resect it here, there's no mucosal lesion. There would be the diverticulum that's associated with the diverticulitis, but there's no ulcerated lesion or anything like that. Okay, first question, so pause, and then we will answer it. Okay, so a 25-year-old Caucasian male is referred to a gastroenterologist by his family physician because of recurring abdominal pain, diarrhea, and a 15-pound weight loss. The gastroenterologist performs a colonoscopy and identifies several aphthous ulcers in the colon and a few in the terminal ileum. A biopsy reveals transmural inflammation with aggregates of lymphocytes identified both in the submucosa and muscularis propria. Of the following was the most likely diagnosis. So there's transmural inflammation. They're presenting with a chronic diarrhea, abdominal pain, weight loss. And so it'd be Crohn's disease. Ulcerative colitis would not be transmural. Irritable bowel syndrome doesn't have such prominent pathology. Pseudomembranous colitis, there's no description of a membrane on the surface of the mucosa. Zollinger-Ellison syndrome, there's no esophageal webs or anything like that. And then diverticulitis, it's not inflammation. It's not an acute process he's presenting with. He's presenting with workup of a chronic process requiring biopsy. So the answer is Crohn's disease. Okay, second question. Pause, then we'll answer it. A 61-year-old female presents to an acute care clinic complaining of diarrhea and pain on the lower left side of her abdomen. The pain began 2 days ago and has worsened. She reports that 2 years ago she had a similar episode, but it was not as severe and she did not seek medical care. She has a past medical history of hypertension, treated with medication. She does not smoke and has been married for 41 years. She had a hysterectomy 3 years ago for uterine fibroids. Her vital signs are blood pressure of 121 over 82 millimeters of mercury and a temperature of 99 degrees Fahrenheit. Physical examination reveals tenderness in the left lower quadrant it should be of the abdomen. Of the following was the most likely diagnosis. So this is a perforated diverticulum. So it's relatively acute onset. She's in an older age group when they occur with age. She has a little bit of a temperature, and she has a tenderness in the left lower quadrant. So it's perforated diverticulum. Acute appendicitis could occur, but you'd see it on the right side. Angiodysplasia causes GI bleeding. Ovarian carcinoma, possible with tenderness in the left lower quadrant, but it wouldn't really explain the diarrhea, the other features, and is more likely to perforated diverticulum. And then you would always want to consider atypical anginal pain, but of the choices there, the best one would be the perforated diverticulum. Okay, so then once again, use reflection, think back on the lecture. What are 5 important points you learned from it? And like I said, I hope I taught you 5 important points. And like I said, make it stick says medical student went from bottom of the class, top of the class using this one technique. I used it in college without knowing it, and then I didn't know about it in medical school, and then recently I've started using it more after I read Make It Stick, and it's a great way to learn and cement the material in your mind. And then here is Glacier National Park. This is actually a crime scene occurred here. Me being a forensic pathologist in Montana, but this is a very scenic view looking down. Like I said, if you're ever in Montana, ever have a chance to go to Glacier National Park, well worth a drive, very scenic. Thank you.